I'm moving forward every day. Jesus, I just let him lead the way. Every second, every minute, every hour of the day. I'm moving with Jesus every day. 24/7 with Jesus every day. 24/7. I'm moving with Jesus. I'm moving with Jesus every day.
Hi, and welcome to another installment of What Comes Out of a Man, a health series where we take a deeper look into our bodily functions we tend to take for granted. Do we really need to go every day? Go where, you ask? Well, today's guest is Dr. Rambhajan, a general surgeon, and he is going to take us on a journey from digestion to the final result. And I'm your co-host, Joleen Meharris-Simpson. Welcome, Dr. Rambhajan.
Hi, Joleen. Thanks for having me and good morning.
Hi, it's a pleasure.
Thank you.
So tell us more about digestion. I mean, we know the stomach is involved, but what other organs play a role?
Well, digestion is a complicated process and it starts really from the mouth and ends at the anus. When we take food into our mouths, the first thing that starts with in terms of digestion is the mechanical aspect of digestion, which is chewing and grinding our food into a product that can be easily swallowed. And in chewing, the food is also mixed along with saliva. And the food is then pushed into the back of our throats or our pharynx to start the propulsion phase of digestion. In saliva, there's also enzymes or an enzyme called amylase, which starts the breakdown of some of the sugars or starches that we have in our foods. The next phase of digestion is propulsion of the food down our esophagus into the stomach. And this is probably one of the phases at which, worldwide, but definitely in Trinidad as well, a lot of problems start to arise. And problems I'm talking about is gastroesophageal reflux disease, or commonly known as acid reflux.
We should not eat too fast.
What I'm saying is, so at the junction between the esophagus and the stomach, we have a sphincter called the lower esophageal sphincter. And the purpose of this is to prevent food and liquids from exiting our stomach and getting back into the esophagus. Right? Once the food gets into our stomachs, it starts to mix with acid, which continues the breakdown process. And it also mixes with some other enzymes that will start to break down proteins into amino acids to allow for absorption. But the stomach is well suited to deal with acid inside there. However, the esophagus is not suited for that. And acid reflux or gastroesophageal reflux disease, which commonly would manifest itself as heartburn, is when this acid gets out of the stomach or exits the stomach and gets back into the esophagus.
Okay, so is there anything we can do to avoid that
Right.
happening?
Simple lifestyle changes that are good patterns to avoid heartburn, as well as just good eating habits in general. One is appropriately chewing your food. Back in the days, they used to say chew your food 32 times. I think that's probably a bit of overkill. And it's probably also a coincidence that we have 32 teeth in our mouth.
Right.
Or supposed to have 32 teeth in our mouth. So that's probably where that came from. I'm not saying to chew your food 32 times, but chew your food appropriately. Food should most times not be mixed with drink.
Right.
So we ought to eat first, followed by drinking 30 minutes after eating.
So you're saying to have your plate of food on your table with your juice and eating and drinking at the same time, that's not a good habit.
It's not a good habit, especially for patients or persons who have problems with heartburn.
Okay, got it.
We ought to eat sitting up as opposed to lying down. And we ought not to eat within 2 to 3 hours of going to bed.
Okay.
The smaller our portion sizes are as well, the better it is in terms of two things. One, not putting on too much weight, and two, avoiding heartburn or acid reflux. Right? It's probably a better practice to eat 5 or 6 small portions per day as opposed to 3 large portions for the day. And those are really simple lifestyle changes that could be done to avoid acid reflux and improve your overall eating habits. From the stomach now, food exits the stomach and gets into the duodenum, which is the first portion of the small intestine.
Okay.
And this is where a lot of, some of the further breakdown of the food takes place, but a lot of the absorption of the food takes place, right? So the chemical portion of digestion occurs starting in the duodenum and continuing down into
Okay,
the
and that's
small
duodenum.
intestine.
You said that's the small intestine.
Correct. That's the first
Okay.
portion of the small intestine. Here's some of the ancillary organs of digestion, like the pancreas, the liver, and the gallbladder, have their impact on our digestive process. Apart from producing insulin, which we all know the pancreas does in terms of regulating our blood glucose levels, the pancreas has an important function in digestion, producing about 10 to 15 enzymes that further break down fats, starches, and proteins to allow it to be digested.
Quick question. So can the pancreas produce too much enzymes?
The pancreas does not produce too much enzymes. It can produce, or if it does, it's usually not a problem. It may produce too little enzymes,
Right.
too few enzymes, and these are patients who may be afflicted by chronic pancreatitis or multiple episodes of acute pancreatitis where the pancreas has become burnt out and no longer functions the way it ought to. The other thing that aids in digestion is bile, which is produced in the liver, stored in the gallbladder, and then excreted into the duodenum, or that first part of the small intestine, to aid with the digestion primarily of fats, or the breakdown of fats.
Okay, and if our gallbladder is not functioning well, what could happen to us?
Right, the gallbladder is a big problem area for persons living really in the Western world. Trinidad, no different from that. 95% of gallbladder problems are due to having gallstones, right? So the function of the gallbladder is to store bile and eject bile into the small intestine when it is needed. When it is needed, meaning when there's fat sitting there. Now, for a number of reasons, that bile that is sitting in the gallbladder could start to coalesce and form like gravel, silt in the gallbladder. And as time goes by, that silt may turn into stones. In our part of the world, the most common reason for stone formation is secondary to cholesterol.
Right.
Doesn't necessarily mean having too much cholesterol in your diet, but there are a number of things that may factor in. Females are more likely. As with age, the chance of developing gallstones is also more likely. So more so with people over the age of 40. Pregnancy promotes gallstones as it inhibits the way in which the gallbladder contracts, right? Patients who've had previous surgery on different parts of the small intestine, obesity promotes gallstones, as well as rapid weight loss may promote gallstones.
Okay, so many different organs play a role in this digestion.
It is a very, it is a very complex thing, and obviously with the more things that have a role or part to play, the more things that could go wrong, or the more things that we need to look out for, right?
So where are we now? We're in the small intestine.
So we're in the small intestine.
That's called the duodenum.
Right, the first part of the small intestine is the duodenum, right?
Duodenum. Good, I got that.
And that is about 12 inches in length.
Okay.
Then the other two portions of the small intestine, the second portion is the jejunum, the third portion is the ileum. Both of those portions together primarily function to absorb the breakdown products of our digestion.
Okay.
Right? So the chemical digestion has taken place already. Our carbohydrates have been broken down into simple sugars for absorption. The fats have been broken down into fatty acids and glycerol. And our proteins have been broken down into amino acids. So now everything is ready for absorption. Inside the lining the inner walls of the jejunum and ileum, there are these tiny little hair-like protrusions, and that is meant to increase the surface area to allow for more effective absorption, right?
Yes, what?
So the nutrients here are absorbed into the bloodstream.
Directly into the bloodstream.
Directly into the bloodstream, and it will pass to the liver first for metabolism to begin to occur. So at the end, once the food, which is no longer really food anymore,
exactly.
gets out of the ileum, which between the jejunum and the ileum, that's about 20 feet of small intestine.
20 feet.
20 feet
but
of
Doc,
small
how is
intestine.
that 20 feet fitting in
It
a
is
small
really
area?
tightly wound, tightly wound and packed inside there.
Amazing.
Then everything exits into the colon.
Right.
Right? The colon starts, so the small intestine largely is in the center of the abdomen. The colon then starts on the right side of the abdomen, winds across the top, comes down the left side, and down into the rectum, down towards the anus. The primary function of the colon is to reabsorb water.
Okay.
Right? And it also absorbs some vitamins, vitamin B12, vitamin K, but the primary function is to absorb water.
Mm-hmm.
Once the products have gotten into, reabsorb water, and excrete undigestible materials, the fibers that we intake mostly.
Okay.
This is then made into stool or feces, exits into the toilet.
Right. So now that digestion has taken place,
Right.
it's time to go off. Doc, tell us, should we avoid going off? I mean, I'm busy, I'm at work, I need to go, but not right now. Plus, I don't want to go to work. I want to wait till I reach home.
Right.
Are there negative effects?
There is a potential negative impact of this. This is a very common problem where people do not want to use the toilet in public spaces, or they think they're too busy to use the toilet. And what this tends to do over time is it causes a feedback where your colon may start losing its natural urge to go off. When you constantly delay going off, when you have the urge, you constantly delay going off, your colon may start or may stop telling you when it is time to go off. In other words, you will not get the urge and your colon may start to back up with stool. And this is one of the more common reasons for constipation, and it's probably more so common in the pediatric population than in the adult population. But constipation in and of itself is really just a symptom.
Okay. Thanks, Doc. We're just going to stick a pin right there, stop for a short break, and when we return, we're going to talk more about problems that can occur in our digestive system.
Al cielo voy en carroza con mi Salvador. Al cielo voy en carroza con mi Salvador. Quiero estar listo para el día final. Señor, Señor. Al cielo voy en carroza con mi Salvador. Al cielo voy en carroza con mi Salvador. Quiero estar listo para el día final. Señor, Señor. ¿Estás listo, mi hermano? Oh, sí. ¿Estás listo para el viaje? Oh, sí. Espera a Jesucristo. Oh, sí. Espero la carroza porque listo estoy. Al cielo voy en carroza con mi Salvador. Al cielo voy en carroza con mi Salvador. Quiero estar listo para el día final. Señor, Señor. ¿Estás lista, mi hermana? Oh, sí. ¿Estás lista para el viaje? Oh, sí. Espera a Jesucristo. Oh, sí. Espero la carroza porque listo estoy. El día pronto ha de llegar. Voy en carroza con mi Salvador. Con mi Señor por siempre estaré. Voy en carroza con mi Salvador. De mis pecados me librará. Voy en carroza con mi Salvador. Y allí por siempre yo viviré. Voy en carroza con mi Salvador. Al cielo voy en carroza con mi Salvador. Al cielo voy en carroza con mi Salvador. Quiero estar listo para el día final. Señor, Señor. Al al cielo voy,
en carroza con mi Salvador, en carroza con mi Salvador, al cielo voy en carroza con mi Salvador, con mi Señor.
Welcome back. We've been talking about the digestive system and what happens through that exciting, amazing process. And we have with us Dr. Rambhajan, and he was just telling us why it's important not to put off going off. Now, Doc, should people look behind in the toilet when they finish doing their numbers? And how can that help us know more about our health?
Right. I think it's very important that we look behind and see what's there. Things that you're looking for in particular is whether or not there's blood in your stool, whether the blood has been mixed into the stool, or whether the blood is separate from the stool. You're also looking for mucus, whether there's mucus there. And you also want to look at the shape, whether it is becoming very thin or pencil-like stools. We ought to be really very much in tune with our bowel habits and look out for any changes in our bowel habits, as these may be indicators of some underlying problem, some underlying disease process that may be going on, where early detection is likely to be key for a good prognosis. We were speaking about constipation.
Yes, and we know it's a topic people don't like to talk about. You know, you don't really going around saying, well, I didn't go off today. But tell us, if I can't go off, I mean, what can I do to help my situation?
Well, as I was saying, constipation is really a symptom and may be a sign of an underlying disorder. But some of the more apart from putting off, going off, one of the other more common or most common reasons for constipation is really a poor diet. Poor diet meaning inadequate fiber intake and inadequate fluid intakes. Poor bowel habits or bowel processes, putting off, going off. And it's usually a good idea to have a routine about going off, having a specific time a day, so your internal clock tunes into that. As patients get older and they start taking more medications play a role in our bowel habits, poor exercise habits. But it is important that when patients get over the age of 50, that any incidence of constipation ought to be taken seriously, especially being over the age of 50, along with maybe passing blood in the stool, ought to be taken really very seriously. And we get into more so about the talk about colon cancer.
Yes.
Now, colon cancer is really very prevalent in Trinidad. Our exact incidence is probably not well known. However, in North America, colon cancer is the second leading cause of cancer-related deaths in North America.
Wow.
And I imagine we probably have a similar figure here in Trinidad.
So talking about colon cancer, I mean, tell us what symptoms we should look out for.
Right.
Should we get tested? I mean...
Right. Some of the ways in which colon cancer may present itself: constipation, blood in the stool, change in the caliber of our stool, or change in our bowel habits, where we may start developing very thin, narrow stools. Weight loss is another one. Or it is important to note that colon cancer may be there without having any symptoms at all. And these are the reasons why screening is so important when we talk about colon cancer.
Should everyone get screened, or is there a specific age we should start screening?
Right. For the general population who do not have an increased risk factors, and I'll get into some of the risk factors shortly, but for the general population, screening ought to start at the age of 50. Now, the best methods of screening, there's some debate about that. The Canadians have one way of thinking, the Americans, Europeans, etc. But in general, a good rule of thumb, screening is via colonoscopy. Colonoscopy is a mildly invasive test where a camera is inserted and is passed through the entire colon, And it allows the doctor to look at the internal walls or the inside walls of the colon, looking for any abnormalities, whether polyps are growing, because colon cancer doesn't just arise out of the blue.
Okay.
It always or almost always starts as a polyp, which grows and matures into a cancer over a period of 10 years, 5 to 10 years.
But some of us don't like going to the doctors.
Some people don't like to go, or most people I imagine don't like to go to the doctor.
Yeah.
And, this is a fairly taboo subject in Trinidad, but this is really very important. Most or a large proportion of the colon cancers that are discovered in Trinidad are of a later stage, and that is because we are not screening appropriately, or patients are not being screened appropriately at the appropriate time.
Yeah, so then it's really important we schedule that appointment post age 50 to get that screening done. How often should it be done?
Right. So, given provided that the first screening test is negative, the first colonoscopy is negative. Negative meaning there aren't any polyps and there's no signs of colon cancer. The next screening test is at 10 years.
Okay.
So this
that's
is
not too bad.
Exactly. This is not something done on a yearly basis. And that's for the general public. Now, people who are at a higher risk of colon cancer, people who have a strong family history, 2 or more first degree relatives, meaning is what I mean by a strong family history. Patients who have certain syndromes, HNPCC or familial adenomatous polyposis should be screened earlier. Patients who have inflammatory bowel disease, particularly ulcerative colitis, ought to be screened earlier. There are a couple other, less common reasons to be screened. Patients who are at increased risk of colon cancer, patients who have had previous colon cancer, breast cancer, endometrial cancer, ovarian cancer confer increased risk. And some of the things in our diet, colon cancer is not as common in Eastern countries as it is in our Western countries, and that is a direct function, or I think is a direct function of our diet. Where in the West we eat more fats, more animal fats, we eat more red meat, and we eat a lot less fiber, and these things promote the development of colon cancer with time. So I think a big take-home message here is screening is important. Colonoscopy is a mildly invasive test, but it is absolutely essential in everyone 50 and over.
Good, very good information for us today. Let's talk a bit about other conditions that could occur in the digestive system. I hear a lot of people talking about celiac disease. What is that about? Right.
Well, the gluten-free craze the gluten-free diet has become much the craze in the Western world. Whether that has started really because of celiac disease or more so as a marketing campaign, I'm not going to comment on that. But celiac disease is an autoimmune condition whereby gluten in the diet, so gluten is a protein that is found in wheat, barley, or rye, right? Our flour products by and large. Gluten is a component found in that, and in celiac disease we produce antibodies triggered by that gluten component, and the antibodies damage the villi or those hair-like projections that I was talking about earlier on that we have in our small intestine. When these hair-like projections are damaged or flattened, as occurs microscopically, our absorption is severely impaired. So we develop malabsorption. Weight loss may present as abdominal pain, diarrhea, overall failure to thrive. Some patients will start developing a specific type of rash. There will be vitamin deficiencies as we're unable to absorb our vitamins any longer. Patients may start developing fractures in bones that are not really very common. And I mean, this is a big health problem. Celiac disease itself, or true celiac disease, is really relatively uncommon, however. But there are some patients who have a true gluten insensitivity. Or sensitivity, I should say. Where they don't have celiac disease, they don't have the malabsorption, but they do have the abdominal bloating and fullness and abdominal pains that occurs when they're exposed to gluten. So while they don't really have celiac disease, eating a gluten-free diet may be of some value, or gluten poor diet may be of some value to some of those patients.
So for these persons, when is it time to see the doctor? Because some people might say, well, I have gas, or have a weak stomach. I mean, what are the signs that should say I need to see the doctor? This is not normal.
Right. Now, any sort of abdominal complaint, especially young folks, we are not immune to abdominal troubles, right? Especially in young folks who have recurrent abdominal complaints, occurring on a regular basis and ongoing, greater than 2 to 3 months, definitely ought to see a physician for that. Patients who are older, in the 40s and definitely over the 50s, would not be doing themselves great justice in delaying to 3 months or so before seeing a doctor, because the likelihood of something sinister, something more serious going on is more common in the older age groups, right?
Exactly.
And this kind of gets us to the story of irritable bowel syndrome, right? IBS. IBS is really very common, extremely common worldwide. It affects about 30% of adults.
How do you know if you have IBS?
Right. The diagnosis of IBS is a difficult one to pin down because it really is a diagnosis of exclusion. A lot of other things could cause the same symptoms that present in IBS. A lot of other things like acid reflux, gallstone disease, gastroenteritis, colon cancer, inflammatory bowel syndrome, celiac disease, etc., right? So confirming IBS is really very difficult and maybe a costly and laborious process that may entail upper endoscopies, lower endoscopies, and a whole slew of testing. But really, IBS, for the most part, is a stress-related disorder.
Okay, what are the symptoms?
Symptoms, just like in celiac disease and very many others, diarrhea, intermixed sometimes with constipation, but diarrhea is more common. Abdominal pain, abdominal bloating, abdominal cramps. People may notice that they have spikes in symptoms or worsening symptoms at times of high stress, changing jobs, unemployment, moving house, starting a family, etc. So these are some of the things to look out for as it relates to IBS and other disorders.
So doc, there's someone looking on and they're saying, I have some of these symptoms, but I'm afraid to go to the doctor. Can you just share a word with them to encourage them why they need to see about this problem?
At the end of today, the big take-home message I would really like to impress upon the audience, and this is not just for men, this is for men as well as women, is at the age of 50, everyone needs to be screened for colon cancer using a colonoscopy. This is done by a gastroenterologist, or some surgeons perform colonoscopy as well. And any abdominal complaints ought not to be ignored, especially complaints that are ongoing, that may be increasing in severity, ought not to be ignored, and you ought to seek care by a qualified physician.
We would like to thank Dr. Rambhajan for being here with us and sharing his knowledge and expertise on the digestive system. We are indeed fearfully and wonderfully made. So remember to take care of your body, which is a temple, and get Jesus inside of you 24/7 and let him take care of what comes out of you.
Thank you for viewing JC 24/7. Be sure to subscribe to our YouTube channel and remember to inspire your living as you prepare for heaven. You can get it all on JC 24/7.